Welcome to part 2 of the lecture on motivation and counseling. In this lecture, I'm going to start to talk about how we can support our clients' motivation through different approaches and techniques. Before I get into the details, I think a couple things need to be mentioned. First of all, my ability to comment on supporting the motivation of children is limited since I don't have any direct experience working with kids. The textbook by Ziviani goes into that in detail. That being said, I think one thing is clear to me from what I have read of the literature based off of motivation in children, and that is, with few exceptions, the practices and principles that support motivation in adults also support motivation in children. And since, for example, self-determination theory basically argues that the processes that support optimal motivation, such as need support and internalization, are innate processes, then of course they're going to be present in kids as well as adults. There probably are some wrinkles, some things that are slightly different, such as the need to be a little bit more supportive and directive and maybe limit setting in children. And I'll talk as much as I can about how to do that and still satisfy a children's need for autonomy, or at the very least, not thwart it. I think the same can be said for how applicable these ideas are to persons with intellectual disabilities, whether they're developmental or acquired through TBI. There is a small body of literature out there suggesting that, for example, autonomy support in individuals, children, and adults with developmental intellectual disabilities has its benefits and is superior to taking a more controlled approach. Okay, so that being said, I think another general concept or idea to start with comes from this quote from Edward Deci, one of the co-founders of self-determination theory. And this is from a TED Talk that you can find on YouTube. He says, "Don't ask how you can motivate other people. That's the wrong way to think about it. Instead, ask, how can you create the conditions in which other people will motivate themselves?" And so I think that a lot of the attempts speech pathologists make to motivate their clients are very direct, such as persuasion or providing rewards. Whereas I think what is probably more of an effective approach is being a little bit less direct, more indirect, and I think that'll become clear what I mean by that as we go through some of the different methods. In general, when we look at studies, meta-analyses, and systematic reviews, which is what these references are, we see that needs support has positive outcomes associated with it that are relevant to what we do. So greater autonomous and intrinsic motivation, improved engagement, higher quality learning, meaning learning that is more conceptual and less rote and memorization, better task performance. Increased effort and goal persistence, particularly goal persistence in the face of various challenges, which of course most of our patients experience at one time or another. Improved psychological health, such as reduced depression and anxiety, which are common in my clients. And overall, a preference for ever increasing challenges. And that's what we do in rehab, isn't it? We set goals for patients, they meet them, and we keep raising the bar on them to maximize their outcomes. Now, what happens if we don't support all three needs? Those studies that I just referred to were studies wherein people were having all three needs satisfied. What seems to happen is if we only satisfy one or two needs, we get more controlled forms of motivation. And if we think about internalization as being something that happens to different degrees, in other words, we either partially internalize something or we deeply internalize the reasons for doing something, identify with it, integrate it with our other goals and values and beliefs. And so, because self-determination theory says that in order for deep internalization to happen, we need all of the needs supported, it makes basic kind of superficial sense that only supporting some of those needs will result in some internalization, but not enough perhaps where we get into autonomous forms of regulation. Right? That internalization might be shallow, and therefore we get introjected regulation, right? That state wherein we're acting because of that should voice in our head is telling us we should, and we feel some pressure to behave in certain ways, to act in certain ways, and it's pressure that we're putting on ourselves. Okay, so let's talk about the specific techniques for supporting autonomy. And let's start with a quote by Ryan in DC that I think kind of captures nicely the spirit of what we're up to when we're supporting people's need for autonomy. And they say, a climate of autonomy is conducive to more integrative processing, involving more of the client's reflective capacities, emotional awareness, ownership of actions, and depth of processing about meaning and values. There are many intricacies to these capacities and their expressions as springboards of change. So, if you are seeing clients now, ask yourself, and I ask myself this often, and that is, how much reflection is going on in your sessions? How often are you creating the opportunities in the space for your clients to express their opinions and to reflect on their opinions and what they believe and what they want? It's easy to not do that in the course of trying to ensure that we get through X number of exercises. Overall, autonomy support is accomplished through taking the client's perspective, encouraging reflection, exploration, questioning, offering choice, providing meaningful rationale for our recommendations, and in general, making sure that we minimize any pressure to behave, to believe, to act in any certain directions. The first place to start with autonomy support is what we would call perspective taking. And what we mean by perspective taking is essentially that we're listening to our clients with an intention of trying to understand their viewpoint. I think of it as kind of trying to see the world through my client's eyes and listening with that kind of an attempt. And of course, we're trying to see the world through our client's eyes as it relates to their disabilities, as it relates to the goals that they might have for treatment. As simple as this sounds, I think it's rarely done. I know from my own experience that I can always listen better. I can always pay more attention. I can always turn up the sensitivity of my antenna, so to speak, and listen to not just what my clients are saying, how they're saying it, their body language, all of that. And this kind of listening, this kind of perspective taking, I think is absolutely necessary. It is the foundation for really any successful needs support, because I think in order to make good decisions about other ways of supporting autonomy, like providing choices and meaningful rationales, we first have to understand our patients, right? We have to be able to provide individualized treatment to them. And the same can be said for the ways that we support competency, etc. So listening is, for me, something that is a kind of a practice that I have to continuously remind myself to do with intention and not be on automatic pilot. And, you know, part of good listening is giving our clients the opportunity to tell their story and encourage them to express their opinions and do what we can do, either verbally or non-verbally, by simply nodding our head in agreement, of validating their perspective. And in general, I think that just that way that we listen, our patients pick up on that, and that itself is validating. It's telling our patients that we respect their point of view and think it's important. You know, when we listen to our clients over time, maybe not the first session, but over time we'll have a better understanding of what the barriers are that they're experiencing. And everybody has somewhat different barriers and challenges that kind of are roadblocks to them achieving an optimal outcome. I think this kind of listening is a way of short-circuiting what in psychology is called ego involvement in therapists, right? So ego involvement, when talking about a therapist, is this kind of unconscious, often, need that we have as therapists to press our point of view and provide our opinions. There are certainly there's time for us to do that. part of the art, I think, is knowing when to do that and when to shut up and listen. Really, there's only one study that I know of that looks at the effect of something like just perspective taking and not other autonomy supportive behaviors, and tries to measure how that affects motivation. And this study by Kostner and colleagues did that, and basically it was a survey of college students, and they were asked to identify 3 individuals who were important to them and were supportive of them achieving their goals. And then these students were asked questions about their own motivation, their own goal progress, and also about the style of those people who supported them. And as it turned out, the people who supported them, wherein their style was described as more just kind of listening and trying to understand as opposed to giving advice, that those individuals whose supporters were primarily good listeners had a more autonomous sense of motivation and better goal progress. The next way we can support autonomy, and very much related to perspective taking, is encouraging our patients to explore and reflect on their goals, their impairments, the challenges they might face. To some degree, this is a process of simply increasing our clients' self-awareness. And I find it hard-pressed to think of a condition, a disorder, that I've seen where my clients did not benefit from increasing their awareness and the accuracy of their awareness about their disabilities and everything that went along with it, such as, again, understanding the different challenges that influence their performance, understanding their strengths and their weaknesses. Now, of course, in some of our patients, particularly those with neurologic impairments, sometimes they have, real organic reasons for having awareness problems, and it's well known in that population that you can't really move forward very successfully in rehab until you do improve people's awareness, because at the most basic level, of course, people aren't motivated for a problem they don't think they have. But beyond that kind of crude example, I think that we all want our clients to the extent to which they can, right? And so children are not going to have the capacity for a reflection that adults might have, etc. But nevertheless, to the extent that our patients can, we want them to take ownership over the process. We want them to be we want them to be responsible for guiding their rehabilitation and their recovery, because of course, basically 99% of the time we're not with them. And so improving speech and other behaviors requires a certain amount of persistent online awareness, a certain amount of intention in the direction that we put our efforts, etc., etc. this encouragement of exploration and reflection on our patient's part also helps us avoid what in motivational interviewing is called the expert trap and the writing reflex. The expert trap is simply that kind of presentation that we have, the dynamic that we set up in our sessions that communicate overtly or covertly to our patients that, we're the professionals, we have all of the answers, and their job is to do what we say, right? Maybe we do have the answers, and obviously we should have knowledge, expertise, things like that. I am not suggesting that we don't provide opinions, our opinions, that we don't make recommendations. I'll talk more about how to do that in an autonomy supporting way. Again, the skill is knowing when to and how to come in with our expertise. The writing reflex is related to the expert trap, and that's simply our reflexive behavior such that when a patient is complaining of a problem, they have a concern, they don't know what to do about it, or it appears that they don't know what to do about it, that we rush in with a solution. So the writing reflex always comes out of good intention, but at a very fundamental level, it often robs our patients of having the opportunity to try and problem solve through the issue themselves. And that kind of problem-solving practice when it comes to managing a disability is really, really key. Whether our patients are always successful at doing that, to some degree, is not the point. Although I think that we need to, at times, provide some guidance so people can feel successful doing that. But first, we have to just establish the basic kind of tone in the room when we're with our patients, that is the dynamic, that is the way things are done in therapy with Dr. Beal. So this exploration reflection also is the way that we guide our patients to identify their own goals, and the research right now is abuzz with this idea of the importance of client-centered care and client-centered goal setting. Well, we can't get there if we don't ask people to encourage their curiosity. We don't ask them to reflect on what's important, etc., etc. There's a 16th century, I believe, Christian philosopher named Blaise Pascal, who said something that's often quoted in the motivational interviewing literature. I don't remember it verbatim, I'll paraphrase it, but he said something to the akin to people are always better persuaded to do something for their own reasons than for reasons that other people give them. And we talked about reasons as kind of being motives. Reasons are the energy for motivation. And so we want our clients to come up, to be autonomously motivated, to come up with their own reasons for why they're there in our office, rather than trying to convince them of some good reasons. And our reasons may be quite good. But again, it's a psychological dynamic wherein it's better if our patients discover those reasons. Again, understanding that if our patients simply can't do it, then at a certain point, of course, we might ask them, well, what do you think about this reason for exploring this goal? So there we can see you've kind of presenting a reason in a way that is not telling somebody what the reason is, but is indirectly making a recommendation, but also acknowledging the person's autonomy, of course, because we're asking their opinion. This is an interesting study by Davis and colleagues, where what they did was they had some college students and they were investigating what they called construal of goals amongst students. And what they mean by construal is interpretations for how the reasons why someone would pursue something or how they would do it. So what they did was they kind of established, here's a goal. The goal is for you to get good grades in your classes. One group of students was asked the question, why do you pursue the goal? And then the students would write that down. And then the next question would be, well, why are the reasons that you gave important, right? And then after that, they were asked again, well, why were the reasons that you gave about the reasons, right? So essentially what this was doing was ask people to kind of go deeper and deeper into their reasons why. And they compared that to what they called low level of construal, where people were asked, how will you pursue that goal, followed by describe how you would pursue what you just said you would do, etc., etc. And what they found was that these students involved in the high-level construal tended to view their academic goals after this process, when surveyed, as more meaningful, reported more motivation to pursue those goals, and perceived those goals to be more self-concordant, meaning more in harmony with a person's values, beliefs, life goals. So the nuts and bolts, how do we encourage our patients to reflect, explore? In general, it has to do with some simple counseling techniques, such as using a higher proportion of open-ended questions, doing reflective listening and summarization. So reflective listening is where we repeat back verbatim or with some slight interpretation what someone just said. So for example, if a patient said to me, it's important for me to practice this goal because it'll help me get better grades. Okay, and then a reflection might be, oh, so doing these strategies will help you, will increase the chance that you get good grades. What that tends to do is two things. One is it simply demonstrates to our patients that we're listening, and and therefore that supports autonomy. And number two, reflective listening tends to cause people to continue to elaborate on that reflection that you gave them. Summarizations are essentially reflective listening, but we may have done a number of reflections, and then we get to a point where we might want to kind of summarize all of those reflections, based on what a person has said over the last 5 minutes or so. And that, again, can encourage a person to continue to elaborate in ways that they think are important. Ziviani, your Ziviani text, they've got lots of good examples in that chapter on kind of motivational language of different examples of ways of asking questions that ask people to explore a wide range of things that are motivationally relevant, everything from, questions about goals to questions about confidence and people's abilities to achieve those goals. I find that I ask a lot of questions that I never asked before in therapy, and maybe I didn't ask them because some of them I kind of was afraid to ask them. But something like as simple as, you've been my patient for a month. Does this feel like it's helping? And if they say yes, well, why? Tell me a little bit more about why you think it's helping or how. Or if they say no, okay, well, why don't you think so? We can learn a lot about our patients from doing that. And I think that that act also encourages this kind of metacognitive thinking in our patients. And, our patients will have insights simply from our probing them and asking them in the moment to reflect. And so they'll learn about, what might be helpful for them and what's not so helpful and why. And oftentimes for me, that will result in tweaking the treatment plan. And now the treatment plan is starting to be guided by the patient, and the patient feels more a sense of ownership of, everything they're doing makes sense to them for their reasons. So that's a good place to be. And you can see examples of other questions here. Now, we need to step back and realize again that people have different capacities for exploration and reflection. Some studies out there on things like where we're asking people to come up with their own rationales for why they're doing something or why they should do something, that literature has shown that in general, people who have high degrees of confidence that they can achieve goals or respond really well to that, do well with that. You can kind of be very open-ended and not do a lot of support. But people with lower levels of confidence can get overwhelmed by us asking these open-ended questions. And so the recommendations there are often maybe, provide some preamble of possible rationales for why something might be important, and then ask your patient what they think. Sometimes with some of my clients, I'll have like a whiteboard or a piece of paper out there, and I'll just kind of jot down keywords as is it for this reason, that reason, or whatever I'm kind of asking them to reflect on. And so in general, we just have to be sensitive to the fact that we might need to provide different kinds of support to different people, and that would also mean, obviously, framing the question and the potential rationales in ways that people can understand and are relevant to them. Finally, this is just a little technique, comes from motivational interviewing that I think is sometimes helpful when we want people to elaborate, and particularly when we want them to elaborate in certain directions and in more positive directions. It's the use of a 0 to 10 scale, right? And so the way you would do this in order to promote more elaboration and reflection is something like, let's say I asked you, okay, so this is the goal that we're going to start off with. I'm just kind of curious, on a scale of 0 to 10, 10 being the most important thing you could imagine, how important is this goal to you? And if my client says, oh, it's important, it's a 9 or it's an 8, then, oftentimes we want to engage our patients as much as possible to keep talking about why this stuff is important to them. In that case where they said a 9, I could say, oh, okay, well, why a 9 and not a 7 or an 8? And it's just a simple little trick to keep people talking. That, besides using scales like this, I think that these kind of subjective ratings are really important for us to do, because they're another kind of measure of improvement. And, oftentimes we'll learn something about our patient really clearly that wasn't so clear just from interviewing them. For example, at simply asking a client, how good do you think your speech is right now? 10 being normal. And sometimes you'll see people who have really, really good speech, and you would expect them to rate their speech a 9 or an 8, and they rated a 3 or a 4. And that self-perception is going to influence their motivation to do different things, to be more social and things like that, and probably will influence their interpretation of the different successes and failures they experience during rehab with us. So, knowing that can be really important and might lead us to kind of pay a little bit extra attention to helping to shape and move people towards more accurate self-assessments and more positive self-assessments. Probably the most studied form of autonomy support is providing choices to clients. Of course, one could say that choice is at the heart of what we call patient-centered care, client-centered care. Choice is an expression of self-determination and autonomy. We need to be clear that when we talk about giving patients choices about their care, we're not talking about abdicating our responsibility and just letting patients decide what happens. That's not really autonomy. That's kind of encouraging people to be independent. And what we want is to provide the kind of information, education, guidance, and meaningful choices that our patients can make kind of something more akin to a true choice, a choice that is true because it truly is in the best interest of the client. It comes from a place of confidence that they understand why they're choosing what they're choosing. Now again, the nature and extent of choices will vary based on the client and the context. Some clients need more support than others. In general, when working with adults, I find that people who are in the very acute stages of rehab, they've just had a stroke, let's say a week ago, that choice can be overwhelming for them. And the research on client-centered goal setting and what's called shared decision making in rehab attests to the fact that for many patients, particularly in acute rehab, they want their therapist to choose for them. And that is an expression of their autonomy. That is an autonomous decision to have the therapist decide. I think we still, want to have the kind of conversations with our clients that at least open the door for them to play a larger role in making the choice about what happens, and then see how they respond, and then that'll help us understand how far to take that. So again, we need to demonstrate some sensitivity there. What I find is, even with my outpatients, is that oftentimes at the beginning of treatment, they're looking to me to make more of those decisions. But if I do my job right and I educate my patients in the coming weeks or months, that my patients get to a point where they truly can make more genuine and confident choices. So we want to provide, if we are providing a list of choices, right? So in other words, we can have what we would call free choice, which is you simply ask someone, what goals would you like to pursue, versus providing them, let's say, a menu of choices. And if we do that, then we want those items to be relevant and meaningful. Again, how good of a job we do at perspective taking, and the reflection exploration part will help us offer more meaningful potential choices. I think we want to, in that case, we want to provide choices that are achievable. And we don't want to overdo choice, in the sense that we can provide choices that are too complicated. We can provide too many choices. The research on what is the right number of choices to provide, if we provide choices, is a meta-analysis by Patel et al., one of the references there. And they looked at a bunch of different domains, academics, I believe sports, etc. And their conclusion was 3 to 5 choices was what people can manage. I think that for some of our patients, Perhaps if they're very young or they have cognitive impairments, maybe fewer choices would be appropriate. We also have to be careful about not indicating too strong a preference for one particular choice of the menu of choices that we offer, because of course that will naturally instill a little bit of pressure on our patients to feel like they should choose that option. What are the kinds of choices we can make or engage our patient in making? Really just about anything that happens in treatment. Everything from the goals of treatment, the kinds of treatment approaches we will take, the criteria for success before the patient moves on to the next stage of the treatment or goal, what we're going to test for, even simple within session tasks, kind of choices. You know, you've been working on 3 different goals in your session, and you simply ask your patient, you know, which exercise would you like to start with today? Many opportunities for choice. Once you start thinking about giving more choices to your client, and that's on your radar screen, I guarantee you, you will see choice everywhere. And again, I think we need to always be mindful that we don't kind of exhaust our clients with choices. Again, I made reference to this meta-analysis by Patel. A couple other things they found in this meta-analysis was that it appeared to be that the positive effect of choice was even larger for kids than it was for adults. It was positive for both, but with children it seemed to make even more of a positive difference. They didn't really go into why that was the case, but it was. And overall, when we look at how important a choice was, the effect sizes were in the small to medium range, which in general, from my experience, is kind of true for all of the different motivational interventions that we can potentially do. Quite honestly, that's often true for all of our treatments too. They have small to medium effect sizes. The next area of autonomy support is providing meaningful rationales. And we can think of this in 2 contexts. One is in providing recommendations, and this would go along with providing choices. But also there may be times where choices are very limited, or we only have one recommendation, in which case rationales are, and good rationales and rationales done in autonomy supporting ways are even more important. This is also related to when we're asking clients to engage in some activity or course of treatment that we think is beneficial, but may be, for whatever reason, very uninteresting to the client. So what can we do in these particular situations to increase the chances that clients will adopt our rationales in an autonomous way? This very recent review by Van Steenkist and colleagues basically identifies 2 overarching approaches. One is paying attention to some of the features of the rationales that we provide, and the other is the way that we provide them. So let's start with the features of the rationale. First, they should be specific and concrete rather than vague and abstract. Van Steenkiest give the example of a study done where individuals were given a rationale for why they should learn an exercise called Taibo, which I believe is some kind of martial art. And one group was given the instruction that it was important for their future. And the next group was given a much more specific rationale for the health benefits. And those individuals that got the more vague rationale became motivated, but in a more controlled and interjected way. In other words, they knew that they should do it because it was important for their future health, I guess. But they didn't have enough information, I guess you could say, to really agree with it and for it to really match up with other beliefs that they had. Similarly, I think we could think about when we give rationales for why someone should follow a course of treatment, maybe a rationale such as because it'll improve your speech is not enough. Another thing that seems to be relevant is giving intrinsic versus extrinsic goal rationales. Now, when we talk about intrinsic and extrinsic goals in self-determination theory, we're actually talking about something different, related, but different than intrinsic and extrinsic motivation. When we talk about intrinsic goals, we're talking about goals that are characterized by a few things, such as that intrinsic goals tend to lead to personal development, whether that's improving one's health, improving the relationship that one has with others, or doing something that is virtuous, like helping others or something like that, whereas extrinsic goals are goals that are more about getting material wealth, achieving status and approval from others. This would include achieving a level of power or, let's say, attractiveness. And so in general, rationales and goals that are framed in terms of their intrinsic values, their pro-social values, their health-oriented values, maybe their psychological health values, tend to promote more autonomous motivation. And then finally, whether or not our rationales are containing any new information or whether we seem to be stating the obvious. When we give rationales that are restating the obvious and what our clients already know, those rationales don't tend to be very motivating. What is motivating is if we can provide some information that our clients may not know, and so we can build on the motivational reasons for why a person might do something. In some of the SDT literature, this has been called revealing the hidden value of some goal or course of action. We want to give rationales in an autonomy supportive way. So this means not only providing meaningful rationales that come from our understanding of the client's perspectives, but accepting any negative feelings and resistance that the client might have to this particular goal. And if we are in the business of taking our clients' perspective and creating a space where they feel free to tell us why they may not want to follow a recommendation, then of course we can use that information to say something like, I know this sounds boring and uninteresting, or whatever we need to say. What appears to be the case is that there are multiple studies looking at finding ways to help people be autonomously motivated for things that they're not really interested in doing. And the three most important factors seem to be providing meaningful rationales, acknowledging people's negative feelings about engaging in this pursuit, and not using any pressuring language. Pressuring language might be saying something like, you should do this, you must do this, you need to do this, rather than finding ways to say it in a little bit more of an inviting way. Another way we can encourage people to adopt our rationales is, or let's say adopt a course of activity that they may not be initially very motivated for, is to ask them to generate what they think are some good reasons why they might want to consider doing this. Again, clients who are already kind of low confidence that they may be able to successfully follow this course of action, we may have to provide them, let's say, with a few different rationales and ask them which ones they think might be true for them, as a way of supporting their decision. So there has been a recent meta-analysis on the effect of rationales on motivation, showing that compared to not giving somebody a rationale and just kind of saying, you need to do this and this is what we're going to do, there's far greater autonomy. People will tend to value the task more when they're given good rationales, greater engagement, etc. Again, intrinsic goal motives, which is what Steingut et al. Referred to as autonomous and prosocial rationales, have a positive influence on motivation. And they also found that rationales might actually reduce the sense of competency in individuals who already have low confidence. Again, what we apparently need to do with these individuals is spend a little bit more time both kind of elaborating on the rationale, and what seems to be true, at least for kids, is that with high confidence individuals, you can use rationales that are a little bit more abstract, like this will be good for your grades, for your future, to be successful, etc. Whereas with kids with low confidence, it seems like rationales that are much more concrete and address things that ways they can be better in their immediate future, right now, in their daily life, seems to allow these students to engage in these activities with a little bit more self-endorsed reasons, a little bit more autonomy. And again, along with that is, as I've mentioned before, providing a series of a list of potential rationales that, as therapists, you glean from understanding the patient might be meaningful to them, and then have them choose. And then I would say that once they choose, is asking them why they chose that, right? To get them to start to elaborate on their own rationale. So in that sense, by giving choice, we've given them some support. They choose a rationale. We ask them to elaborate on that, and now they're starting to self-generate rationales like some of the higher confidence individuals might do. Another way to engage in autonomy support is to generally do the things that we can to minimize pressure. And we minimize pressure in a few ways. First of all, by removing all sense of contingencies, right? In other words, we don't want our clients to feel in any way that they will be punished for not behaving, I guess, the way we would like them to or recommend, nor that they will be rewarded for doing so. In the previous lecture, I talked about how sometimes punishment is quite concrete, like if you don't do this, you'll be discharged from therapy, but more often it has to do with us kind of communicating our positive regard or giving patients our approval for behaving in ways that we like. And somehow, if they don't, communicating to them that we're not so pleased. And people are quite sensitive. We don't have to say it outright. If anything in our demeanor changes, people will pick up on that. And now they won't like that. They want us to approve of them and care for them. And so if they see that that they have to behave in a certain way to achieve this approval, they will start, often unwittingly, behaving in ways so that you will approve of them. But now their goal is not really about what they want. We want to avoid controlling language, which I've talked about. In general, we want to follow our clients' needs. We can see this with kids in doing, play therapy my understanding is an accepted way of doing therapy, and I think it kind of takes advantage of this notion of following our clients' leads in terms of what they want to do in therapy, how they want to explore their recovery process. Again, this will depend totally on the patient and the disorder. And then finally, what we would call roll with resistance. When we get resistance from clients, we don't want to, in a knee-jerk way, jump into convincing mode to try and push them out of resistance. Sometimes we have to let our patients kind of sit and bake in that for a little bit, or maybe come at it from an angle and try and establish a dialogue for why they don't want to do it. And if we do that in a way that makes it clear to our patients that we will not judge them or think any of the less of them or care any less for them if they start to say things we don't want to hear, if we can find a way to communicate that kind of acceptance, people will open up. To finish off with autonomy support and its relationship to the other needs, autonomy support is by far the most commonly studied way need support that is studied. Right? So we see autonomy support being studied more than competency support or relatedness support. Autonomy support appears to be highly correlated with satisfaction of the other needs. In other words, if we're really doing good autonomy support, we tend to also be supporting people's needs for competence and need for relatedness. Right? The need for competence, for example, when we allow people to choose, they tend to choose in the directions that they feel competent that they can be successful. And so there we can see how both autonomy and competence is supported at the same time. And the optimal theory referenced here by Wolf and Lewthwaite, which is a motor learning theory, a different theory from self-determination theory, but gets some inspiration from self-determination theory, addresses this relationship between autonomy support and confidence. Okay, so that's it for part 2 of my lecture on motivation. The next lecture will focus on competency support, relatedness support, supporting self-efficacy, which is in many ways identical to supporting the need for competency. And then I'll say a little bit about goal setting and the role of hope and how to manage unrealistic expectations.